Just want to be respectful to my co-presenter, so I want to go through. So I'm going to go talk about LV function assessment with nuclear and cardiac CTA, mainly LV ejection fraction, okay? And other things. Okay, Dr. Malafji is going to be my presenter. I'm going to pick on you. Who is Dr. Brownwell? Anybody know? Who doesn't know Dr. Brownwell? Is he a rising star, or is, okay. Okay, so I guess you never know he's a nuclear cardiologist, right? So this is a paper published in 1960s, toward the end of 1960, okay? And guess which technique he used to estimate LV volume ejected. So EF, ejection fraction, wasn't even coined as a term. It was coined by Dr. Gorlin a couple of years after this paper was published. So this is one of the first non-invasive imaging to estimate LV ejection fraction using nuclear technique. It's a dilution technique. Essentially, you inject radioisotope and capture with a camera that you can see there. And Anyway, so this is from historic perspective why we come back. And other things, a lot of dogma that we know about in cardiology is based on ejection fraction, and most of the study was done with the nuclear techniques like this one. When do you operate mitral regurgitation, or when do you administer and monitor cardiotoxicity chemotherapy? All this was done to the point that only cases that we get for nuclear assessment of ejection fraction right now, maybe some diode or oncology, that one, that still miss MAGA, I guess, only trust MAGA. Okay, so anyway, so how do we assess ejection fraction using nuclear technique? There's two major techniques here. One, we inject radioisotope. Okay, you can label with red blood cells. Basically, so it goes to where the blood is, called blood pool. So you look at LV cavity. So essentially similar to what you get with LV gram, right? Okay, so it's a count based. So basically you count the activity within the confine of what you think the LV cavity is in a different part of cardiac cycle. You can do it with what we call first pass. It's a dynamic study. You inject and you look at how the tracer bolus goes through the vein, go through the PA, go through RV. I'm sorry, go through the vein, RV, PA, left atrium, and come out to the left ventricle. So it's a dynamic study. I don't think we have done that ever for the last 20 years. But occasionally we still do equilibrium radionuclear angiocardiography, or MAGA for short. It's a planar study, but you can do tomography. We probably did less than, 5 or 10 for the last year. It's rarely done anymore. But I think there's some special use in certain clinical scenarios. The second one is more important because this is what we do daily and day out with myocardial perfusion or wall imaging. So unlike the first technique where you image the blood pool or LV cavity, this one you are imaging the LV wall. Okay, so you really need to know the part of cardiac cycle you're imaging, right? So so instead of count based, this is a volume based. So you can tell by the big difference with the first technique is there's no confine for due to geometric assumption, okay? And for volume based, like any other techniques, there's a geometric assumption. So, and it is important because it's part of the free information you get when you do a perfusion study. And it's important for you to understand that for the first technique, you can assess RV function, but with the myocardial wall imaging, the RV wall is thin unless you have very good image quality. Sometimes PET probably, but even PET for RV as function assessment, I don't think it's, correct me if I'm wrong, Mahmoud, but I don't think it's done routinely. So this is just a quick example. This is more for historical perspective. So you can see in the left lower panel, you can see how the tracer go from the venous circulation to the right side of the heart and exit from the left side of the heart. And basically you get your best angle similar to LV gram, so you can separate the chambers and you kind of localize the area, regional interest where you think the LV is, and you subtract the background count activity. So you can see this is purely count based, okay? And this is one of the first technique people use to do what we call functional study. You can assess, LV function with exercise, RV function with exercise, and also quantification of cardiac shunting. I think it's a lost art, but physiologically, it's a very interesting technique. Okay, MAGA is something we still do occasionally. So instead of first pass, so this is an isotope that you inject, you label the red blood cells. You can label them in vivo, meaning that you inject the isotope directly to patient's vein, or you can draw blood in a tube. You label, you kind of tag them with the isotope, and then you inject back to the patient, and this get cleared by the liver. It takes a while, so it gives you a lot of time to images. Again, you can image the patient just like LV gram, different projections. You can see the RV, LV there, and so essentially the ejection fraction is calculated when you have the count at end systole, end diastole, minus count in end systole over count in end diastole. So very simple concept, right? And it has been proven to be very accurate compared to LV gram, which used to be the gold standard, and the dosage that you give is relatively acceptable. So what's the advantage? No geometric assumption is well validated, very reproducible. Well, I don't think we're going to do diastolic function assessment. Disadvantage is obviously the planar images. In RVEF, you cannot assess with MAGA because it's difficult to separate the chambers. The source errors are mostly technical. And to tell the truth, I think the only time I would get a MAGA is probably in an LVAD patient, okay, where you cannot get a CT because of the renal function, you cannot go to MRI, the echo window is poor. And we've done a couple of them. I think it's a underutilized technique for heart failure specialist, and for LVAD patient, I think is something to be considered, okay? Okay, gait spec. This is the thing that we do day in and day out. And the importance of this slice is I just recertify my nuclear bore, and this is one of the questions. Everybody's probably paying attention now. Okay, so you know the gated technique we use in almost all the cardiac non-invasive imaging, CMR, CT, nuclear. So with nuclear imaging, you know, you image the patient over, depending on the protocol, 12 minutes, right? So you put all the beads, and you kind of put them in different bin, and compress and compile them into one single beat, okay? So depending on the heart rate, if your heart rate, you know, is reasonable, you can separate the cardiac cycle R, each R interval into a frame. And that gets you relatively well-validated ejection fraction, okay? So what happens if you say, okay, I want to be more accurate, you can see the curve, the time and volume curve. If you increase the number of frames, let's say from 8 to 16, you're more likely to capture the true end systolic and end diastolic volume, correct? Okay? So the board question is, if you have a 16 frame versus 8 frame, what volume is the one that affects the EF calculation? I show you, the answer is in the bottom one, okay? So the EF with 16 frame is higher. And that's due to, and the difference is end diastolic volume or end systolic volume? End systolic, right? Because end diastolic volume, you can tell, I mean, you have plenty of chance to catch end diastolic volume, right? Cardiac cycle-wise. To truly catch end systolic volume is harder. So the difference, you can see the end diastolic volume is the same, but with 16 frame, end systolic volume is smaller. Therefore, the stroke volume is higher. Everybody follow this? Ask question, otherwise this go 150, there's 100 questions, this is one of them. Okay, so the difference between 16 frame and 8 frame is because the end systolic volume is much more accurate. Okay, it doesn't affect end diastolic volume as much. So if you get a better end systolic volume, your stroke volume is going to be higher, correct? Your stroke volume is higher, your EF is going to be higher. Okay, that's it. Moving on. All right, so this is how it looked like. I'm not sure why it's not playing. Okay. So you can see the perfusion, and so you got systolic and then diastolic, and you basically, it's a 3D assessment. It's automatic. It's a mix of geometric assumption and also artificial intelligence, because it cannot detect the myocardial edge based on the count. So they fix a threshold where you think, okay, if this is conductivity, this corresponds to the myocardium, and some complicated math function that I have no idea. Essentially, you can look at this really crude images, you say compare to MRI or CT, but amazing thing is, clinically, it's actually very useful. So I'll show you an example of a normal one, and this will be a abnormal one, okay? Much larger volume, multiple area with decreased count activity, low ejection fraction. The key here is it is a very reproducible, okay? We're not talking about accuracy or how precise. It's very reproducible, meaning that if you do it every single time, unless a patient had horrible arrhythmia, I you're gonna get very good EF number, okay? And across the reader, essentially, there's very little variability, unlike, for instance, echo, right? So it's very reproducible, and compared to both volume and EF, and regional wall motion is a little bit harder, it's much less validated, and we all agree. It's very hard unless it's very clear. It's hard to diagnose regional wall motion in the gated SPECT images. So all and say, what are the caveats, okay? The key here is we're detecting the wall, right? So if the patient has a huge transmural myocardial infarction, no counts, sometimes you won't be able to localize. For instance, the patient with apical aneurysm, sometimes it's hard. Or you can have extra cardiac activity, okay? So, and the second disadvantage is really, SPECT has really poor spatial resolution. And due to partial volume effect, it's gonna give you some very low systolic volume in the patient with very small heart, therefore you're gonna get EF sometime crazy, like over 70, 80, 90%. Arrhythmia is obviously hinder all the basically gated study. And RV, I'll talk about it. And we talk about the impact of 16 frames versus 8 frames. And the last thing is there's a lot of software out there, use different algorithms, so the EF could sometimes vary up to 5 to 10% using different platform. Okay, the key here is when you read a nuclear study, okay, before you jump in to look at the images, always look at the raw data and the sinogram, because this sinogram is gonna tell you how well the gated information is, okay? So usually, obviously, our heart rate is not always constant. And if the heart rate is very variable, if you think it's end-diastole in the R interval of 60 heart rate, 100 heart rate is going to be very different. So by convention, you accept about 10% each side of the average heart rate, meaning the heart rate is 70. You will accept any R interval between 70, 72, and 80, roughly, for heart rate of so 90 to 100% interval. And for a gated study to be acceptable, you need to have at least 80% of beats not being rejected, okay? If you have PVC more than 1 in every 6, I wouldn't get EF that you're gonna get is not gonna be us. So another board question. Frequent PVC, advanced heart block, and very irregular AFib, do not gate the study because you're gonna get a false EF, okay? Remember that. Again, this is arrhythmia. This is how you detect gated problem, okay? Stripe, horizontal stripes, spikes, compared to this much more smooth count histogram. You see all this all over the place, okay? So this is your quality control, very important. If you see this, the EF you get is not reliable, okay? And this is another example, okay? You can clearly see a patient with a huge anterior septal infarct and in the right-hand side, okay? So you're gonna have a hard time tracking where the myocardial border is, but oftentimes I should say, you'll be surprised how well this algorithm works because the number you get is still, even they can, the algorithm can detect counts activity that our naked eyes cannot perceive. And the left-hand side, you have heart, liver, any extra cardiac activity. Okay, we see that all the time, right? Small heart, because the partial volume effect, you get this EF from 91%, which obviously, and the Japanese has a lot of experience in this because almost all the Japanese women, the EF is over 70% because their hearts are very small. So this another board exam, okay? So I give you 3 already. Reference value, again, you can see the lower limit of normal is usually lower for men and usually lower compared to MRI. So when you get an EF of 55% and with our 4DM spec, it's probably equivalent to 60% in your CMR. Okay? Maybe not be perfectly normal. But for women, usually, it's definitely 55%, maybe a little bit lower. For men, I think it's 50-55%. Well, should be. Okay, so this is another other area where the board exam is focused a lot. What's the clinical utility? Why do we even want to gauge the study? I mean, there's no extra dosage, no extra imaging. Whenever you get perfusion with SPEC or PET, you're going to get the EF. So it would be a waste not to use this, and besides, it's very useful. For instance, improve diagnostic accuracy, basically exclude artifacts, so make your reading a lot more specific, okay? You're gonna have much less false positive. And it help you in cases when the perfusion is not very equivocal, help you decide if the study, is truly abnormal or it's just an artifact. For instance, TID, post-stress EF drop, stunning, and essentially this is a major use. And that's the board exam is going to ask you. The main thing is you add prognostic information, which obvious when you get EF, when you add EF to any other functional parameter, is going to improve your prognostic predictive value. But the main use of gated spec is to help you improve your reading diagnostic accuracy, okay? Anyway, so this is just a prognostic paper. I mean, nothing, obviously. If you add functions, the perfusion is, your overall model is going to be more robust. And this is probably the most important use of this, right? I mean, you see it every day, right? You have women with a large breast size, obese men with elevated diaphragm. So for women, for instance, a fixed defect in the anterior wall, normal gated, and this most likely is artifact, okay? So this is the most important use of gated information. Okay, this is what I talked about earlier. This is a study done with PET. You can see using a different software, EF is very different. Okay, you can go from 67% with ECTB toolbox to 48%. Big differences. So know what's the normal value of the package you're going to use. And this is the same thing I mentioned for SPEC, apply for PET. The difference is PET, you imaged a little bit earlier with rubidium. The EF drop, rest and stress EF difference is also a predictor of outcome, okay? Whether it's normal, scar, mild, moderate, or severe, when you add difference in the EF, or what we call EF reserve, increase your prognostic value, and you can detect much more cases of balance, quote-unquote balance ischemia if you use TID, EF drop, basically all the tools you use to avoid false negative, right? So not only help you with avoid false positive with the artifact, in certain cases can help you increase your, to avoid false negative study, okay? All right, moving on, CT, okay? Why do we even want to do CT-EF, right? Well, occasionally you get a patient like this, you get a patient with, and the patient with TAVR, you can see with the contrast, EF is a little bit maybe mildly depressed. It would be very hard if the patient, after TAVR, to decide if the EF improved by 5% or 10%, right? I mean, it's not easy. Obviously, ideally, you can have a patient at MRI before and after, but not always possible. It's very expensive, but since everybody get a CT, for instance. So just look at these images compared to Okay, unfortunately. Oh yeah, there we go. I mean, I don't need to convince you which one is more reproducible, and so we almost never do EF assessment with CT, but when you have the information, you gotta utilize it and report it, okay? Especially for the RV, which is a very difficult chamber, the images, and CT offer, if you properly contrast, you can really calculate the EF very accurately. Okay, all right, so how do we assess the volume? Okay, well, main advantage, just in case somebody cannot get an echo, cannot get an MRI, and renal function is reasonable, radiation is not a big issue. It's a very easy test. It's probably the easiest test to do for EF assessment. You do it in single breath hold, almost in every patient. In white detector scanner, you can get an EF acquisition time of one single heartbeat. Nothing beats the speed of a CT. You get true isotropic spatial resolution. Personally, I think should be the gold standard because the spatial resolution is the best of all the imaging technique. Reasonable temporal resolution, as long as your heart rate is now over 60 or 65 or even 70, I think the spatial temporal resolution of CT is pretty good in getting the accurate EF. And obviously, it has a pretty good contrast, not as good as MRI, but very good contrast between the lumen and myocardium, and you can do it in patient with device. And the cornerstone of the technique is isotropic resolution, okay? All the 3 dimension, we have a spatial resolution of 0.5 with a newer scanner. Technically, they're talking about 0.25, close to the LV angiogram, but we gotta see that. All 3 dimensions, so essentially what allows you to rotate and really calculate how many voxels in each structure. Essentially, voxel is the volume in 3-dimensional space, and all the same, with all the same spatial resolution. Okay, there's a couple ways of calculating. So we're talking about, so this is how we calculate the volume. You can do 2D, just like MRI echo, okay? You can do Simpson method. And the key here is obviously where you determine, where you decide where the valve plane is and the apex is. Okay, and that's geometric assumption. So this is 2D methods, just like most of we used to do. Okay, what truly is different is what we call threshold-based 3D segmentation. Here is, so I don't want to say it's similar to the MAGA that I showed you earlier. So here you can trace the endocardium, and you can have you can actually calculate. You can have the cast, right, of the cavity, LV cavity of any chamber actually you want. Okay, so and if you know how many voxels is in end diastole, how many voxels in systole, you can get the EF relatively. So the beauty is, the reasonable study, this is all completely automated. Basically, you set a threshold about which you think that's blood in each cavity versus myocardium. You get the 3D method. But most of the software we use combine also AI to allow us to do the segmentation. So obviously, this is kind of like this is a slide provided by GE, by Siemens. Kurt is one of the scientists. Obviously, this is there's nothing particular about this algorithm. It's basically they validate, get output, and then they get a predictive, and then they compare, and then. So all this was done automatically. You don't need to do any interface. This is all completely automated. You can adjust it a little bit, but you can adjust the threshold, but the principle is the same. Okay, so this is most of the time what we get, for instance, for LV and RV in the right side, okay? Okay, so that's how we calculate the volume. How do we actually, what protocol do you need to get ejection fraction? Number one, obviously, traditionally, we do retrospective ECG gating. We image the entire cardiac cycle, and then find out the lowest volume. So for accurate assessment of EF, you still need to do retrospective ECG, okay? But for true assessment of EF, you can actually do step and shoot. So meaning that basically you can image the patient from, technically from the started R wave as your end diastole, and then you can go to just include end of systole around T wave, right? You can get about 0% and 30%, and technically, or 35%. You're gonna get approximate EF, right? Maybe not enough to say it's 55% or 60%, but it should be normal, with much less radiation, okay? And obviously the image is not gonna be very smooth because you only have certain number of images. I don't know, you guys are too old to remember when we do the myocardial perfusion with echo, basically, you only see end systole and diastole. Okay, so you can get kind of like fairly decent EF information even with step and shoot if you want to. Okay, so, I think I missed it. Okay, even with the flash mode, the same thing. With flash mode, you can trigger end systole and diastole, and basically you have only two phases. Okay, end systole and diastole. And we're currently validating this approach to see, because compared to retrospective gating for calculation of EF. All right, what's the main difference between 3D and 2D? 3D methods, if you do threshold base, it's going to be a little more accurate because it's going to would only calculate. So basically, you trace the LV cavity, and 2D methods depend if you include the pump muscle or exclude. I know with MRI you exclude the pump muscle. CT were more practical. We include, make it faster. We care about our fellows, Imagine you have to go through all the single pump muscles, and if you have so many slices, you can just spend whole day tracing. All right, so other caveat is 2D is obviously very time consuming, a lot of user interaction, systemic errors, and they have to be free of step artifact. Remember, with retrospective gating, we're imaging the heart. Unless you have a white detector CT, we image the heart about 4 to 6 beats. So if you have major R interval difference, you're going to have mistake artifact. In 3D, you need obviously good opacification and homogeneous, and have enough difference between the myocardium and the LV cavity in order for you to get an accurate segmentation. And AI is kind of has similar problem with 3D methods. Compared to CTA, this is use 64 slices retrospective gated protocol. I mean, it's as close as you get with the MRI, which is considered gold standard right now. I mean, for research purposes, maybe there's difference, but for clinical, really, unless barring major rhythm differences between the two studies, I mean, you should get very similar number with MRI. Okay, the EF and volume, the same problem. Okay, with the gated, this is also gated. So if you have very fast heart rate, EF is not going to be as accurate. Remember, we need our temporal resolution is about 55 milliseconds, so 65 milliseconds. So we don't get more than 10 to 12 frame cycle per. So in order for us to get accurate EF, we need to have a slow heart rate. Okay, so compare MRI, CT underestimate because of the temporal resolution issue. Okay. Again, the same thing. We talk about A frame versus 16 frame in SPEC, 10 phases versus 20 phases. Okay. You can see a subtle difference, right? I mean, 20 phases, you see a little bit more, looks smoother. And with the threshold base, you can exclude the pump muscle if we want to. The other caveat, if you give beta blocker, you know, the CT, you're going to underestimate. You get radiation and iodine. Okay, so this is the normal value. You can see it's probably also similar to MRI, but this is done in a different scanner, type of scanner we have. I think the scanner will make a big difference because of the temporal resolution. And like any other gated study, you can use parametric display for wall thickening. But this is the one thing I want you, besides ejection fraction, I think this is very important to help you interpret a CTA study, the coronary information. If you have any lesion and you have wall motion, so basically this is a patient we did two phases flash mode. Okay, let me see if I can play it one more time. You can clearly, even when I'm training now, you can see clearly the apex and apical anterior wall doesn't really, apical septal doesn't work very well, and there's some perfusion differences, so that lesion you see is clearly very significant. Okay, I'm going to go through this. So, no surprise, EF getting with the CTA, add prognostic value when you add it to the coronary information, it's a surprise. And this is done also in ROMI-CAT study. You have EF, wall motion, and CTA. Usually that's pretty severe. It's the same thing with the resting wall motion abnormality. So any stenosis you see is going to be significant. So kind of in conclusion, volume and EF assessment and nuclear and CT are feasible and very accurate. And importantly, provide additional prognostic information. I would add also improve your diagnostic accuracy. Okay, interpretation of the study. And patient with difficult image by echo or unable to do MRI, or if you want RV assessment, you can think outside the box besides echo and MRI. MAGA SPEC study and CT could offer if you really need it. And for patient undergoing CTA images for coronary disease without prior EF assessment, like in the ED, when we do ED, oftentimes we get CT before they get the echo. And if you can have some EF information, you help to triage the patient more efficiently. Okay, any questions? No question? I just want to show you okay.
Thank you, Dr. Chang. I'm going to talk about CMR, and unfortunately I don't have any board review questions for you, but I'll try to think of some when I go through this, so I'm on my left for those who I haven't met. As Dr. Chang alluded to, ejection fraction has been the reference for almost all of what we do, and you can almost assume that the first question to any cardiologist in the hospital is, or by any cardiologist, is what's the EF? But I wanted to give you some caveats with this. So these are two patients that have an ejection fraction that's estimated and calculated at 65%. But notice this patient has severe mitral regurgitation with a flail posterior leaflet. And as we calculate their LV volumes, we notice that this patient, well, I believe this is actually my own heart. I got scanned a couple years ago. EDV 164, EDV 259. And then you get a stroke volume. This is the planimeter stroke volume. Notice that this stroke volume is 107, this stroke volume is 168, but with the severe MR, a lot of it is going back into the left atrium. So they're actually both ending up with a similar stroke volume. And in the way that this patient leads or ends up with a similar forward stroke volume or cardiac output at rest is by enlarging the left ventricle. So just assuming that the two people are similar because of the ejection fraction being similar is not very accurate. This patient has severe heart failure, EF 23%, very large ventricle, but he actually is able to achieve a similar stroke volume to those two. So this is the first message, which is ejection fraction doesn't necessarily mean the cardiac output, and it doesn't really incorporate LV size, and is obviously very load dependent. The challenge is that meeting criteria for an ideal index of LV performance or systolic capability is difficult. You have to find a parameter that's sensitive to changes in inotrope. It has to be independent of load, independent of heart size. It has to be easy and safe and prognostically relevant. And we haven't really found a parameter that's as good as ejection fraction, despite all of its caveats. So we're still using that, but I want you to remember that. Now, this is another important message that came out over the past few years, which is there's this relationship of LVEF and heart failure. And obviously there's heart failure with reduced EF, heart failure with preserved EF, and now there's multiple other subcategories. But the question is, what threshold or number of ejection fraction actually has a relation to mortality, because that's what we care about, or heart failure hospitalizations. In this study, which had 400,000 echoes, you notice that the relationship is not exactly linear. In patients who had supranormal or hyperdynamic LVEF, we always call it in the echo lab, they actually had worse mortality, and this was done very rigorously with validation in an external data set, and they found the risk of heart failure and death to be higher in the supranormal ejection fraction, suggesting that, hey, could there be a, quote, new phenotype of heart failure of hyperdynamic LV, hyperdynamic EF. And to give you the usual profile of these patients, most of them are older patients, most of them are, or more of them are older women also, who tend to have smaller LV cavities, and as a result, you can estimate that their stroke volume is probably lower, and their ejection fraction is hyperdynamic to maintain their LV stroke volume. In this study, they did a whole lot of adjustments to try to correct for that or control for that. Another study that looked at 33,000 patients, these are the main randomized trials of heart failure, and they didn't really establish this J-shaped relationship or curve of LVEF. In this study, in terms of the risk for mortality, the inflection point seems to be somewhere between the 40–50% range, which is what we've considered to be significant most previously and most recently with the most recent iterations. CV death is a little bit more of a linear relationship, but still has a similar threshold. Pump death was more pronounced at 40% or lower. And then sudden death, notice that it's not always as, there's no very clear set point, as you may have heard. So let me talk a little bit about CMR. You know, what I wanted you to kind of keep in mind from the previous slides is that, you know, EF also has more caveats, not just with measurements and reflection of LV performance, but also outcomes. And there's more work to be done in this area, I think. Now, what are the advantages of CMR? You get high resolution, both in the spatial and the temporal domains. Excellent signal to noise, and notice your ability to delineate what part is myocardium and what part is LV cavity. So very high contrast resolution, as opposed to CT where it's more shades of gray. Here it's more black and white. You get free choice of imaging planes, and you can get any assessment of any cavity without geometric assumptions. The way that it's done is that you get tomographic planes or slices through the chest cavity, first to define pseudo-axis, pseudo 2-chamber and pseudo 4-chamber views, and out of those you can create two traditional 4-chamber and 2-chamber views, of which you prescribe perpendicular slices to get a set of short axis slices. And with geometric assumptions being not needed in this scenario, you can just use the true Simpson's formula to get the volume from each of the slices, and you add them up at end systole and end diastole. For us, you know, we calculate the papillary muscles within the LV mass. Tracing it is easier in this scenario, and we use the threshold-based segmentation. The key part is to maintain consistency, and the papillary muscles do account for a lot of the LV mass. In cases such as severe LV hypertrophy and HCM, including versus not including the LV papillary muscles can lead to a significant change in your EF. And the key part is to remember to match or make sure your traditional tracings, or your tracings match with your visual assessment. That applies to whether it's CMR or echo or elsewhere. When you're tracing the LV on CMR, a key thing to remember is the LV descent, and to account for that when you're tracing the insystolic volumes. And notice that for all of this, you don't need contrast. So you can do a CMR study to assess LV volumes and function in 15 minutes without needing contrast. This is very strongly validated against cadaver hearts and in vivo and ex vivo, with very small variation, whether it's intra-observer or inter-observer, and inter-study variability. When it comes to the physics, I'll go through this quickly, and I think we'll cover it in other talks. When it comes to CMR, it's not the same as CT. So in CT, you're getting multiple slabs of the chest, and each of them is just a full study. Within MRI, you're actually acquiring frequency information that's sort of encoded in what we call the K-space. And each line of K-space contributes to the image. So when you're getting one set of acquisition, for example, here in end diastole, you're getting this kind of image. And then as you add more acquisitions, they all add to the entire image, rather than you getting one section and then another section and then a third section. And because of the heart's constant mobility, you have to achieve a very fast acquisition so that you can get an entire image of the heart within a short amount of breath holding, or a short period of breath holding. When it comes to getting cines, this is done somewhat similarly, where you have the patient hold their breath so you can freeze respiratory motion, and then you acquire a series of these K-space acquisitions that are binned to each part of the cardiac cycle. And as you do 6 or 7 cardiac cycles, you can add those up to end up with the cine. So as a result, the acquisition that you see when you load some of our studies is not technically one heartbeat, but rather multiple heartbeats. And this is how it looks. You can get this with a breath hold that's 4 to 5 seconds with very good spatial resolution and a frame rate. If a patient is unable to hold their breath, you can do what we call real-time cine, and this one is in a way acquired similarly to echocardiography. You can see septal interactions, and you can see relation to breathing and heart function, but you sacrifice some of the spatial and temporal resolution by this. With what's called compressed sensing and other newer techniques, you can achieve much higher improvements in spatial resolution and temporal resolution, but it requires a specific sequence and processing time. But you can get very close to this acquisition. Now, more recently, instead of the sonographer or the technologist adjusting and creating all of these slices that I showed you earlier, there's AI algorithms that can actually find the heart and then switch the slices and adjust 4-chamber and 2-chamber, and potentially with very minimal technologist input. Now, one thing to keep in mind is the LV volumes and RV volumes that we get on the MRI are usually significantly higher than what we get on echo. So for men less than 60 years old, the normal range for EDV is about 119 to 203, whereas for echo, it's 62 to 150. And the larger the heart, the greater the variability is. But when you trace a good quality echo study, and you know the patient has had an MRI before, it will be good for you to kind of look and see what difference. Generally, you usually see an underestimation by 40, 50 mLs by echo if you're just doing simple biplane echo with contrast. When you get 3D echo, the difference will be lower. Notice that the reference range now is larger than it is compared to 2D echo. But the end result is, if you underestimate EDV and ESV to the same extent, hopefully to the same extent, you still end up with a similar stroke volume on echo as you get on MRI. The key thing is to remember your echo quality has to be good without foreshortening, and this is most applicable in normally shaped heart without significant wall motion abnormalities. So as a result, your EF will also be still very similar between your echo and your MRI. Key thing to remember is that the ventricular volumes will slightly decrease as we get older, and as a result, your EF will increase due to the relationship that I showed a little bit earlier. And the normal volumes, even if they're indexed, will vary between men and women when it comes to MRI. This is now a 24, 23-year-old study, but there hasn't really been much that came out after to yield us much more new information. So in this simultaneous echo and CMR study, you notice that the bias is about 67 mLs for EDV, meaning underestimation by echo, and then 41 for ESV, and then the bias for EF is minor. Usually, in this study at least, it was underestimation by 3 percentage points, but more often I think we get a slightly higher LVEF on MRI than you get on echo. And then the bias, increases as your experience is not as pronounced with 3D. In this study, there was also a phantom model. So notice how you trace your LV volumes on the echo will significantly vary your end result. So the true volume of the phantom was 150 mLs, but if you trace it this way, which is how we mostly trace it, you'll get 127, and this is what you really should try to strive towards. If you do it too aggressively, you'll get a significantly higher LV volume, and delineation of those particular aspects on echocardiography is what's going to improve your estimation of the volumes as much as you can. This is mostly driven by trabeculations. So in this study, when they traced the MRI similar to how we potentially trace echo, the agreement becomes much better. And I'm going to skip this. So in summary for this section, the volumes are higher on MRI. ELVEF can be slightly higher or slightly lower, but usually not a big difference. And then 2D stroke volume or planimeter stroke volume usually will not be hugely different, and this is obviously critical for your AR cases, your MR cases, your quantitation of shunts. So keep those in mind. Now, beyond LV ejection fraction, you can measure diastolic function. Usually you get slightly lower E and A velocities on MRI compared to Doppler because of the lower temporal resolution. But you can get E to E prime ratio, and those perform fairly well. Measuring TR velocity is difficult because of varied reasons particularly relating to temporal resolution and the constant motion of the annulus up and down. You can get other measures such as your interstitial fibrosis inferred by these ECV and T1 mapping, as well as your strain parameters, and those have always shown promise in multiple studies, but they're not as adopted in the clinical setting compared to just a traditional assessment. You can also look at the mitral annular-systolic exertion, so your MAPSI essentially, and this has shown prognostic significance on MRI beyond LV ejection fraction and in patients with normal EF as well. You can get feature tracking on CMR to get strain. Traditionally, it used to be done with what's called tagging, but that's fallen out of favor for the most part. And here the key part is vendor variability, variability in different software solutions. So similar to echo, it suffers a little bit from that weakness, but this has shown promise in prognostication in various settings. In this study, which looked at patients with ischemic as well as non-ischemic cardiomyopathy, longitudinal strain was prognosticating these patients. So we can look at all of these, but at this point, they're not widely utilized in clinical reporting. Now with artificial intelligence, you can have the AI now trace, and these are now available on just commercial software solutions. It can trace the LV and the RV and the atria for you. In this study, it had very minor variability between the AI tracing and the human tracing for ESV and mass and RV volumes. When it comes to challenging cases, you'll get errors. So you still need the human intelligence aspect. And notice in this patient, let me find a good example. So in this patient with pulmonary arterial hypertension, notice towards the apex, notice how huge the RV still is with the prominent trabeculations, but notice how the software only traced this section of the RV. Similarly here, for example, in HCEM cases, it kind of got lost here in the septum. And for those, you still need to make your adjustments, but this saves you a lot of time, similar to the AI acquisitions by the technologists. So think of MRI for this, and I don't need to tell a lot more to this crowd about MRI. Initial evaluation of known or suspected heart failure. I think heart failure is, there's even studies to support this. Almost all new onset heart failure patients could be candidates for CMR, particularly in unclear cases. And then patients with cardiotoxic agents, patients who will potentially qualify for device therapy, revascularization viability, and then arrhythmias are very important as well. All right, thank you. Questions? Did it that one. All right, we'll see you next week.